And we expect to see more attendees joining as we go, but we want to have our full hour with Dr. Keys. So why don't we go ahead and get things started? So hello and welcome to each and every one of you with us on the call. Today, we welcome you to the Your Health Lecture Series, which is a sponsored program from Michigan State University, College of Human Medicine, Saginaw Valley State University, and Mid-Michigan Health. As I have shared, my name is Heidi Lang, and I serve as the Pre-Health Professions Advisor at SVSU. We are delighted to have you with us today for Dr. Kent Key's talk on the intersection of health inequities, underserved populations, and COVID-19. Dr. Key is a lifelong resident of Flint, Michigan, and he has been actively engaged in the community academic partnered research for over a decade. He's on the faculty at MSU's College of Human Medicine in the Division of Public Health. And as a racial and ethnic health disparities researcher, he specializes in community engaged research approaches and methodologies and has an interest in urban minority populations. Dr. Key comes to us with a number of experiences and credentials. His former position at the Michigan Institute for Clinical Health Research at the University of Michigan Medical School allowed him to sharpen his skills for minority population engagement across the lifespan. In his community role, Dr. Key is quite busy as the Executive Deputy Director of the Community-Based Organization Partners, and he's also the founder of the Community Engagement Studio of Flint. On a national landscape, because he does not keep his talent centered here just in Michigan. So on that national landscape, he serves as the National Administrator for the Community-Based Public Health Caucus of the American Public Health Caucus. He is a 2017 Fellow of the Robert Wood Johnson Foundation Culture of Health Leaders Program. And in spring of 2020, he was invited to serve on our governor's community action team for the state of Michigan Task Force on COVID-19 and health disparities. In June of this year, he authored a resolution declaring racism a public health crisis in Genesee County, which was passed by both the Genesee County Board of Health and the Board of Commissioners. Following his presentation, we will have a Q&A period, so I invite you to use the Q&A portion of the Zoom call to send in your questions. Chat is great if you want to just have conversation or you want to shout out amen, hello, thank you so much. We encourage you to use the chat for that. As a reminder, the session is being recorded. And at this time, as much as you can, because you are muted, please join me in giving a warm welcome to Dr. Kent Key. Thank you, Dr. Key. The floor is yours.
Thank you all, and good evening to you all, almost good evening rather. And it's a pleasure to be here. I'm going to set up the share slide so that we can actually begin. All right, the presentation. So again, good evening or good early evening. I'm Dr. Kent Key here at Michigan State University College of Human Medicine, Flint, where I serve faculty in the Division of Public Health. And we're going to talk a little bit about the intersection of health inequities, underserved populations, and COVID-19. And again, we want to give a special thanks to all of those who sent the invitation to allow me to be a part of the Your Health Lecture Series. So most of that was read already. That's just a little bit about who I am, what I do, some of the hats I wear, and some of them it was just too many to put on one slide. But it's because we do so much work related to the overall health and wellness of communities, and specifically marginalized communities across the nation. So I want to kind of start off by kind of just laying the foundation of underserved populations. So medically underserved areas and medically underserved populations identify geographic areas and populations with a lack of access to primary care services. They're often low-income urban areas, low-income rural areas, predominantly communities of color, and then you also have homeless populations as well. And then we also have the LGBTQ plus community, which often is underserved medically. Intersectionality. So this particular term was coined by Kimberly Crenshaw. She was a legal scholar in the 80s, and the term is to describe the multiple identities that one may have and how those multiple identities make up your total intersectionality. And then she explained earlier on when she was, really coming across and really laying the foundation for this type of work, that our identities are like traffic flowing at an intersection. One identity may flow one way and the other may in a different direction. This particular work that she did started off focusing on experiences of Black women. And the genesis of her work was two different civil court cases that defending two separate groups of Black women. And that's kind of where she started off. But since then, the study of intersectionality has grown to all intersections and identity. And in 2013, Oxford Dictionary of Social Work and Social Care broadened Crenshaw's conceptualization of this term, defining it as the combined effects of one's multiple identities, which includes identities such as race, gender, sexual orientation, religion, and employee status. So we want to talk about intersectionality and the role that that plays as we talk about the impact that COVID has on marginalized communities. Before we really get into that, I kind of want to lay the foundation, because being a health disparities researcher, quite often I use the social determinants of health and that framework to really show how multiple systems, whether it's education, whether it's employment, whether it's the legal system, how these various systems impact certain communities differently, and how the intersections of those systems may also have a different outcome in communities. And so much like the intersections of identity, the social determinants of health creates an intersectionality that encompasses many factors that impacts the health and well-being of an individual or group of people. The overall health is impacted by factors, and health starts where we live, learn, work, and play. The environment we live in, access to education, healthy food, financial stability, and good relationships or connections in our homes and community all impact our health. And the World Health Organization defines health as more than just the absence of illness and disease. And so when we think about the intersection of all of these various determinants and how that impacts overall communities and the overall health of those communities, it's imperative that we understand intersectionality. And I would also just like to offer this thought as well, is that outside of our genetic code, the next code that predicts our, the overall life expectancy is zip code. And there was a couple of years ago, a big campaign around matters and how zip code is a huge predictor of life expectancy. And you can literally be in one zip code or 2 streets over, and your life expectancy is something different. So again, that's more than just an individual. That's the intersection of multiple things, multiple experiences, multiple systems, some being historical, some being cultural, that we must understand. So when we are trying to impact the health of individuals and communities, we have to keep that at the forefront of our mind. It's not just writing a prescription, but it's also looking at the built environment, looking at culture, looking at history, and looking at the systems that intersect and touch the lives of the people whom we are trying to serve. Health disparities, defined as racial or ethnic differences in quality of healthcare. I actually got into health disparities research in the mid-2000s here in Flint, Genesee County. We had what was called the REACH 2010 study, and it was looking, and REACH stands for Racial Ethnic Approaches to Community Health. And it was funded by the Centers for Disease Control. And we were looking at the disparity or the difference. That's all disparity means, it's a difference. The disparity across infant mortality in African-American communities. And so that's just an example of one health disparity, but it's those differences, whether it's access to care, actual health care, the stages of disease, comorbidities, age, or other social factors. And so we often use the word disparities when we talk about this, but oftentimes I like to back up and start talking also about inequities. And I will have a chart coming up very soon, and we'll talk about inequities and disparities, and then we'll get to those intersections. Health disparities terms such as inequity, it's also favoritism or bias or unfair circumstance, unfair or unjust that some groups may experience compared to others. And as it relates to infant mortality in Genesee County at that time, for every one European American baby that died before reaching the age of 1, and that's what infant mortality is, a baby that dies before reaching the age of 1. But for every European American baby that died before reaching the age of 1, we had 4 African American babies dying before reaching the age of 1. And that 1 to 4 difference was the disparity. So here is a graph. This is a model I'm currently working on and looking to publish, because a lot of my work has been around health disparities. And even with the Reach 2010 program, we created some wonderful programs, right? And while they were funded for almost a decade, we significantly decreased the disparity in infant mortality. However, years after the programs were no longer funded, we saw the disparities go back somewhere almost to where they were. So it became apparent to me that we can't just address the disparities. And so I created this diagram or this chart to really give an emphasis of understanding how to really address disparities. So disparities are really the outcomes, right? Whether it's health disparities, it could be in mental health, it could be financial or income disparities. You know, we know that unfortunately, even in today's society, there are by gender, women can be in the exact same job as a male, but yet make significantly less. That's an income disparity. Then there's disparities in education, housing, employment, and access to care. And then there are others too numerous to really name. But before we really can address the disparity, we have to back up and then address the inequities. And the inequities are the systems, the structures, the policies, the practice, the laws, et cetera, that create the environment for the disparities to manifest. So there are some things at play that helps to perpetrate these particular conditions that create and produce the disparities. But then before we can really address the inequities, we have to get to the root causes. And there are normally root causes that are driven by fears or phobias, some type of prejudice or stereotypes, usually from a false narrative, whether it's racism, sexism, ageism, classism, ableism, and all the other isms. And those are normally the root causes that actually drive the inequities, because if individuals have these fears and phobias and they're the ones creating our systems and the governance and the structures and the policies, then they're going to create them from that frame or from that understanding. And then we see the disparities that are produced. So one more domain we must visit before we go into the root causes, and that is the value system. And I would care to say that I believe in this country, we really do not have the greatest value system. And there's a superiority and an inferiority complex within this particular society, where there are some individuals that assign themselves a greater value as a human being than others. And it could be by race, it could be by gender, it could be by ethnicity, it could be by age or sexual orientation. And this creates a power dynamic. And that power dynamic feeds into the root causes. And those root causes feeds into the systems and the structures and the policies, practices, and laws that have been made. For example, think about redlining. Those of you who are not familiar with that, just kind of Google it. And redlining were laws and were put in place to pigeonhole minority communities away from European American communities. And we saw that in those particular communities that were redlined, those were the zip codes that pretty much had the poor health outcomes. So this stuff spills over into how governance happens in housing, in the housing system or the housing industry. And then there's examples of these in probably every other major system or industry that we have. But I just wanted you to see the connection between value systems, root causes, inequities, and disparities. And this will be relevant to all of you who are going into medical school, social work, public health, or any human health or human service occupation, because when people are dealing with issues and problems, oftentimes it's more than just what they're describing to you. Most of it may be systemic or structural, and most of those systems and structures we can pretty much map on this disparities, inequities, and root causes diagram or model that we have here. So I kind of want to jump really quick to COVID and COVID deaths. So as of, I believe, 2019, the US had an approximate population of 330 million people or citizens. And in the United States, we see here COVID-19, these are some hospitalization and death stats that I pulled from the CDC, and they are trended by race. So we see here for American Indian or Alaskan Native non-Hispanic persons, they had 2.8 times higher cases, 5.3 times higher hospitalizations due to COVID, and 1.4 the death times higher than those of European Americans. Same with Asians, again, 1.1 times higher cases, 1.3 times higher hospitalizations, but no particular disparity in the actual deaths. Whereas African Americans, you see it's 2.6 times higher cases than European counterparts, 4.7 times higher in hospitalization, but yet 2 times higher in the actual deaths. And then with our Hispanic and Latino brothers and sisters, we had 2.8 times higher in cases, 4.6 times higher in hospitalization, and 1.1 times higher in actual deaths that we saw across race specifically. And it's important, I'm highlighting and starting off with race because we know oftentimes that race is not the only indicator of marginalized communities or populations, but historically they have predominantly been those communities that have been marginalized. And so this is the impact that we're seeing of COVID, and this data is relevant as of August 18th, 2020. And I just want to lift a couple of statistics and just some information specifically as we look at this. So as it relates to African Americans make up 13% approximate of the population in the US, yet 34% of the deaths due to COVID in the country, and 33% of the hospitalizations due to COVID. And the data on COVID transmission rates show an irrefutable and disturbing pattern that Black Americans are contracting and dying from COVID-19 at rates that far exceed other racial and ethnic groups. Through inequitable policies and practices, which we kind of talked about in that other chart model that I showed you, forced into conditions that elevate their risk for COVID-19, consequently place Black children at the epicenter of loss in multiple domains of life. Systemic racism is the pre-existing condition affording COVID-19 the opportunity to disproportionately impact Black Americans in the United States. And although, again, as you see these statistics, which are just, there is 13% of the population yet makes up 34% of the deaths of COVID for the entire nation. That is alarming. Likewise with our Latinx population. And so Latinx populations are disproportionately impacted by COVID-19. Prevention efforts, including shelter in place an additional burden on Latinx populations due to existing socioeconomic, mental health, and educational inequities. Latinx parents make up a significant portion of the essential workforce. Around 84% cannot telework and are overrepresented in industries at the epicenter of COVID-19 outbreaks, such as meat packing, poultry processing plants, and agriculture. Furthermore, to preserve economic resources, many live in crowded multi-generational homes or rent rooms in their homes to others. The Centers for Disease Control and Prevention data indicated that Latinx people ages 40 through 59 have been infected at rates 5 times that of non-Hispanic white people in the same age group. When we look at COVID and its impact with American Indians and Alaska Native, COVID-19 exacerbates the effects of historical trauma on American Indian and Alaska Native communities. High death rates among elders, parents, and extended family who are central figures in preserving cultural traditions threatens children's ability to overcome adversity. As of July 30th, 2020, up to 40% of all COVID-19 cases in New Mexico alone were American Indian, despite the fact that American Indians are only 9% of the population. So in New Mexico alone, Native Americans, which make up only 9% of the population, made up 40% of all COVID cases. The Navajo Nations, which spans Arizona, Mexico, and Utah, has the highest infection rate in the United States. Transgender and gender diverse youth, they deal with a lot of distress and a lot of trauma. Transgender and non-binary students are also may have less access to school health professions. And in the literature, it is very clear that most transgender students and gay, lesbian, bisexual, transgender students receive most of their social support and get most of their professional health services through school nurses and counselors. but yet during COVID, they don't have this access. These professionals can help meet their social and emotional needs. LGBTQ plus persons who are HIV positive, along with heterosexuals who are HIV positive and have compromised immune systems, are at greater risk for contracting COVID-19. So those are just some of the national trends across race as we see some disparities with COVID-19 and that intersection with minority groups. But then we also want to talk about just particularly the state of Michigan. So in 2018, we had an approximate population of around 10 million people. In 2018, Michigan had a population of 10 million residents. While Black residents make up just about 14% of Michigan's population, they represent 31% or 63,497 confirmed coronavirus cases and 40% of the deaths known to health officials this was as of June 29th. And the intersections, of course, that helps to perpetuate these conditions are race, poor health access, pre-existing health conditions, unclear or culturally inappropriate health messaging and communication strategies, mistrust of the medical community and government as a whole. You could think about Tuskegee, is the Tuskegee experiment, which I often call it by its real name, which was the United States Public Health Tuskegee syphilis study. And you can just look at the water crisis for that when we talk about mistrust of government and the misinformation that happened even here in the city of Flint during the water crisis. Cases by county, let's see here. So for the total state of Michigan, we had, and this again was as of October 19, 2020, we had a total of 143,000 approximately confirmed cases and 6,987 deaths. But if you were to add the actual confirmed and probable with the cases and death, we had a total of 159,000 approximate cases and around 7,300 deaths in the state of Michigan alone. And this right here are confirmed deaths, including individuals that had, so this one was cases, this was cases, and then this one right here was the deaths. And so some of the information, the numbers are the same, but it's just showing you the hot spots where we had the highest cases, which are the lighter blue colors are the higher cases, and then the darker blue colors are where we see lower cases. And so if you are living in Michigan, you probably can see your county. So we're kind of comparing the counties here by case, but then we're also looking at the highest counties that have the most deaths. And most of the deaths, again, tend to be in more minority populated counties in the state of Michigan. So again, just for a second, the contrast between your cases compared to the actual deaths due to COVID. So here, this is by age group. What we see here is cases are in the blue and deaths are in the red. So we see that the age between 20 and 29 tended to have the higher amount of cases at this time, but yet deaths at the time was the 80 plus. And that's when we started hearing the narrative that it predominantly impacts older residents as opposed to young people. And we were hearing that earlier on, even before like Memorial Day and the 4th of July and all of the holidays, after which we started seeing a difference in the trends and we started seeing more infections, more cases, as well as more deaths in younger age groups. Here are the death and cases comparison by sex. We see that more females were contracting have more cases of COVID, but yet more males were actually dying from COVID in the state of Michigan. And then again, cases by race, which we pretty much covered that a little bit earlier, where you can see in Michigan, African Americans had the highest number of cases and also the highest number of deaths. And this is just in the state of Michigan alone. So I kind of want to get to some community engaged approaches to consider. If you are a doctor or a clinician or a social worker or a public health professional, we need to think about some community engaged strategies to consider as we are trying to impact marginalized communities that are most impacted by COVID-19. And so I would say, just kind of looking at some of the literature around community engagement, building relationships and trust is like the most important thing that you can do. And so engaging your patients or your clients or your participants in conversations around their intersectionality. Oftentimes people are not engaged in these kinds of conversations when they're dealing with health and medical professionals. So even engaging with them to understand their perception of their identity and their intersections, and then discuss how those intersections or that intersectionality impacts their engagement in the healthcare system. I can speak just from an African-American perspective. I remember growing up being told that, go to the doctors when you have to, because for years they have used us as guinea pigs. And I remember just growing up, even as an adult, I would call my grandmother before I went to the doctor to try to get a home remedy, because that type of narrative based on cultural and historical experiences has been embedded in my thinking. And so even as an African-American who happens to have a PhD in public health, that still is the first thought that normally comes to me, because culture and history has a lot to do with how people engage and how people maneuver throughout systems, specifically health and medical systems. And then also advocate for resources to support the various and varied intersections of patients. There are so many things that can really come out from having a good dialogue with those whom you're trying to service and those populations you're trying to impact. You can have the most well-meaning intent, but if you don't truly understand the nuances of the experiences of the culture and the historical pathology that your clients, your patients, your participants are immersed in, then you won't understand why they make decisions. I mean, it's easy to tell someone, okay, you have diabetes, right? Or so then you need to lose some weight and engage in more physical activity. But if you don't understand the built environment that they live in, where it may not be safe to go out and walk, the parks may not be safe. They may live in what we call food deserts, or some people call it the food apartheid, where they just have corner stores, but no full service grocery store. And then when they finally do get to the grocery stores, fresh fruits and vegetables are so expensive that they cannot afford them. And it's just easier to get, a $99 McChicken sandwich than trying to get, some fresh fruits and vegetables at the store. Even now with seniors, we have seniors who are on fixed incomes and they're having to make decisions whether they eat or whether they get their prescriptions. So there are so many different nuances that impact the decision-making of the people who we're trying to serve. That is more than just writing that prescription. It's more than just trying to invite them to your program or to your intervention. You must have these types of conversations and develop the type of trusting relationships so that you can truly understand the nuances that your clientele is experiencing, so that you can help better prepare them for the research or for the intervention or for the prescriptions you're trying to give them to help them. And you can also connect them to resources that go beyond just the clinic or the study or the research. And then there's also some social capital building, right? When you do those things I just mentioned, it helps to build trust in the healthcare and medical system, right? And we know right now, even in this climate, people are not trusting the medical and the scientific community, right? They would rather listen to a conspiracy theory than what Dr. Fauci and so many others who are trained in these areas are saying, right? So we have to repair that breach and to create and strengthen trust in the healthcare and medical system. Then it also empowers the patient, because number one, it shows the patient that they're not just a number concerning you, but that you're actually listening to them, that you actually care. It's not just, someone in your clinic or someone in your study and then once you tell them what you need to tell them, you're done with it. No, you're actually taking the time to hear them and help to think some things through with them. And I think that that empowers the patient as well. And then also it helps to strengthen patient-provider relationships. And when I say patient, whether it's your participant in your study, whether it's a client or whether it's a patient, it will help strengthen that relationship so that as you move forward and other things may arise regarding their health, they're quick to trust you as opposed to having as much skepticism as they may have had if the trust and those relationships had not been strengthened. Here are some discussion points and some things to consider. Does using the lens of intersectionality provide a different view of those whom you serve? As a clinician, as a doctor, as a social worker, as a public health professional, if you were to use the lens of intersectionality, do you think that it will provide a different view of those whom you're trying to serve? What role does intersectionality play in assessing the overall health and well-being of people? Does the understanding of intersections of COVID, health inequities, and underserved populations challenge how public health and medical professionals engage with patients and communities? And if so, how? Are there policy implications to addressing health issues as cumulative intersections as opposed to siloed issues of health? And if the problem or issues are intersectoral, would the response cause for a similar framework or approach as well? So if there's intersections that are causing the issues, must the solution also take into account those intersections when trying to create the solution as we move forward? And I'm going to pause here for any questions. This is my third presentation of the day, so I was trying to give you guys an in-depth yet efficient overview of the intersection of COVID, health inequities, and marginalized communities.
So Dr. Key, we do have a few questions that have come in through the chat. And if I could also remind folks to use that Q&A, so we don't want to lose your questions if they get missed in the chat. But one of the questions came in and says, has there been any research into whether the ethnic link to COVID is genetically linked?
I have heard of conversations around that. I have not personally seen studies, but that doesn't mean that they're out there. But we do know that there's a connection with ethnic link and health disparities in general. So I would assume that there would probably be some type of ethnic link to COVID, because when we talk about ethnicity is slightly different than race. And so even within a race, there may be multiple ethnicities. And again, belief systems, cultural traditions, practice, religious beliefs, though all of those things play a part in how people engage. And so when you think about COVID, there are some ethnic traditions where they don't believe in vaccinations or don't want to be vaccinated. So I'm sure that there are some studies that are looking at that. And we do know that that is something that has to be addressed, just as it is in the regular health disparities domain.
Thank you. We've got several others. Someone's asking, what need of the underserved, underrepresented populations doesn't get enough attention? And then on the flip, in addition to that, this person is saying, what can I do to help?
That's a loaded question. What need? I don't know if we can say a specific need. And that's why it's so important, if you're going to engage with or service an underserved population, talk to the people that represent that population. They're your best source of information, right? So if you're going to, let's say, if you're going to talk to the LGBTQ plus population, then get a group of them together, a diverse group of them together, and start talking about what are some needs as it relates to COVID. And I think that they are the best, because I don't think that there will be one need that may be the same across all of those populations that are marginalized. I mean, I think that it would be a disservice if we were to assume that we could just address one need and it would address all of them. And I know that's not what you're implying, but I just want to make sure that I say that, because even when we tailor interventions have to be tailored per community. It's not, everything cannot be a cookie cutter template, and what works in one community or one population does not necessarily work the same way in another.
Thank you. We've got another individual asking, wanting to know what we can do as a college, specifically referring to MSU's College of Human Medicine. So what can we do as a college to make this work a focus and a priority with action?
Well, I have a young group called the Flint Public Health Youth Academy. And these are students that are, some of them are in freshmen, but the majority are in my high school and middle school students. They have every other week, they do talk shows and they talk about various health disparities topics, social justice topics. One thing we can do based on your question is let's start having some engagement. Let's engage. We know we can engage like we used to in person, but the colleges can throw some virtual dialogues with various types of communities and various variations of communities to actually have conversations around this. So I can kind of put this particular question with the question before. Let's say if once a month our college, we pick one of the underserved populations, invite some leaders and some representatives from those populations, and we have this type of dialogue where we're asking them questions about what are some of the needs, what are some best ways and some best approaches to address those needs in the set community, and then what are some maybe historical and cultural things that we may need to be aware of. We can actually do this just by typically having dialogue and engaging, and that doesn't cost us a lot, just some time.
You know, and you mentioned doing this with like primarily the high school students, the Flint Public Health community. We have some folks on the call that are part faculty with the SVSU Public Health major. Is that something that we could open up to either our undergraduate or graduate students to be part of those dialogues that you're happening?
Yes. So it's the Flint Public Health Youth Academy, which is designed, I created that academy right after the water crisis. To kind of introduce, since the Flint youth were experiencing a modern day public health crisis, this was an opportunity to engage them and introduce them to public health. One of the disparities in public health medicine and in research is that people of color are grossly underrepresented. And so this was an opportunity to start having them engage in learning about these particular disciplines and also engaging them into public health. And so this is something that you can definitely have, whatever groups that you're mentioning, they can definitely be a part. We would love to probably invite them to be on some of the panels, and the young people facilitate these things. It's their talk shows. You can catch it on FPHYA, Flint Public Health Youth Academy. That's on Facebook. And then FPHYA 810 on YouTube. So all of the talk shows are on the Facebook, and then we archive them all on our YouTube channel.
Fabulous.
We would love to have some of the students that are in social work and public health and some of these other in medical school to be panelists on our show, especially when we talk about health disparities and health related topics.
Right, fabulous. Okay. We've got an individual asking, what are some things healthcare workers can do during patient care to help strengthen the trust of patients in this healthcare industry?
Well, healthcare workers are uniquely positioned to not only understand what's ailing a person, but really to understand their story. And I think that healthcare workers, if they take the time, again, I think I gave some examples, when you're having these dialogues, start talking about the intersections of it. So for example, I had someone come to me and they were talking about, the fact that, they noticed that children in their neighborhood were, they noticed that there was an increase in like child obesity in their, in their area, in their community. And so I started talking to them because it's easy for me to say, oh, well, they just need to have more physical activity and eat better, right? But because I was having that conversation, I was able to say, well, have you drove and through and kind of looked at the conditions of the streets and the parks? And have you looked to see if there are grocery stores or what type of restaurants are in the neighborhood, and when they are restaurants, what type of options are on there? And so when they got back to me, they were like, you know what, it's so much drug paraphernalia in these inner city parks. Parents don't feel safe letting the kids go out and play. And then there's so many abandoned homes. You don't want, if the parents are not home, you don't want the kids going up and down the street because you don't want anyone snatching them into the home and maybe doing something, traumatic to them. And so then you realize that a lot of the young people are staying home because the parents are telling them, you stay home until I get there. But by the time the parents are there, sun has gone down and it's dark, right? So they're in there all day on computers, on video games, and there's no physical activity happening, and they're snacking on stuff until mom gets there. So once I had that dialogue with that person, they began to understand that it was more than just trying to tell them to do physical activity, and healthy eating, but it's now we have to start talking to the parents and start talking to policymakers to get the parks cleaned up and get the streets safe. And so it's more than just that one healthcare role that you play that's only specific to the health situation. A lot of times it's social as well.
Right. And I know even with the undergraduates at that level, we try and get them to understand, why would we have a non-compliant patient? And oftentimes the answer is, well, they don't understand. I'm just going to educate them more. And I'm like, well, let's dig a little deeper, that it might not be a lack of education. It's the surroundings that they're in. So excellent. Thank you. Another question for you, and they're flying in, so you're good with this format? Just keep throwing them at you. How do you think the number of Black physicians currently in the US affects the health disparities we see among the Black community? And there's a follow-up to that, but we'll go there.
Well, the last time I checked, when African-American physicians were like maybe 6 to 8%, like 6 to 8% of physicians in the country were African-American. Yet African-American communities bear the brunt of health disparities across health indicators, whether it's diabetes, whether it's hypertension, whether it's whatever. And so I think that has a gross, it definitely is there is an inverse relationship to that. Let me give you an example. My fellowship with the Robert Wood Johnson Foundation pre-COVID, about 2 years ago, took some of us to Cuba, right? And we were able to go to Cuba to learn and observe their health system there. Now, the thing that's ironic about Cuba is this. One, there's no silos with the medical school versus the School of Public Health. It all falls under the Ministry of Public Health. The health sector of the Cuban government is the Ministry of Public Health. All doctors, all social workers, all engineers and architects, anybody that have anything to do with built environment, they all have to get certifications in public health because they have to understand how built environment affects the people that are living in those communities. And so when medical doctors do home visits, they're not just asking you, the set of questions to figure out what's wrong with you and going through the book to diagnose you. They're also looking at the house, looking for mold. They're looking for things because they're trained that way. And then here's another thing. Cuban doctors serve in the communities from which they come. So there's so most of the doctors that are in that geography, and I forgot what the ratio is per clinic, there's a certain number of residents per clinic, but they all grew up in the area, so they know the grandparents, they know the aunties, and they know the aunts and the uncles. And there's a certain level of cultural trust that's there. And again, that is something that is needed, especially with minorities who have a historical experience or a cultural experience with medical and governmental institutions in the United States, like African Americans, Native Americans, Asians, and Latinos. And so that's one thing. And then here's the other piece. Even in the medical school, the medical program they have, there are US students that go to Cuba to get medical degrees, and they're free, but they're there for 5 years. They have to learn Spanish, but they have to commit to coming back to the community in the United States again from whence they come. That's part of getting that scholarship, that you have to go and serve the community that you were born and raised in. And I believe that is imperative to building patient-provider trust and relationships. And so because we have so little African-American doctors, and yet we have all of the stigma or through the historical pathology and cultural experiences that African-Americans have had with engaging in the medical and research sectors in the United States, then it's not surprising that we see the type of disparities that we see and the underrepresentation that we see.
Right. That same, as a follow-up on that same question, it says, do you think physicians have inherent biases towards people of different races versus people of the same race?
Everybody has bias to an extent. We all have some type of implicit bias, and that's why it's imperative that physicians, public health practitioners, social workers, all those who fall under health and human services, those even in education and the police, almost every sector, we have to deal with our implicit biases because we then treat people based on that frame. And if we're not honest with ourselves about that, we can actually be doing more harm than good.
Mm-hmm. Are you familiar with a SIM project grant out of Genesee County?
I've heard of it, but I'm not really familiar
Okay.
with it.
Well, let me give a little background. This individual here was a social worker. It just says it placed social workers and case managers in physician offices to address social determinants. It was a grant program that ended. She was a social worker in the project, so she was able to see firsthand the immense need for such a program to continue. Do you know of any programs coming in the future? Sounds like we've got someone who's hungry to get back directly in the community serving in that way.
So what I will say is, send me, you can give them my email in the chat, and if you and I will dig into that and let you know. Just let's do some email exchange. I believe the connection I knew to the SIM was through Suzanne Cupo at the Genesee County Health Department, and I believe that some of the SIM programming also came out of the Genesee Kirk Smith, the Health Coalition, the Genesee County Health Coalition. So I do remember seeing this project in some meetings at those organizations, but I can do some digging and find out for you.
Fabulous, thank you. So for those of you that are interested in that email, I'm going to rely on my colleague Mark Breve from Michigan State.
I can type it in the chat. I can type.
No, you're busy answering questions. Yeah. Mark's going to pull it up. I'm confident he's good about that. He already did it while we were talking about him.
Thank you.
Okay, thank you, Mark. So one of the charts you showed had hospitalizations highest for Native American Indians. And can you share your insight as to why it was not highest for cases and deaths for comparisons?
Let me go back. Let me see which chart that was.
So I was talking about the one where it showed the hospitalizations where it was quite high, but the cases and deaths wasn't.
So I'm looking at it. So the cases were 2.8 higher. Hospitalization was 5.3 times higher, but death was 1.4 times. And so I'm not quite sure exactly why, but I know that the trend, even with the percentage of population that the Native Americans play in the overall population of the country, most of the cases that we saw were out Southwest. And so I think that a lot of the, I don't want to say resources, but a lot of the COVID resources were actually able to be deployed in those areas, because we know that Native American populations, they suffer from a lot of things disproportionately. And that's a whole nother conversation that we can talk about, even from the placement of the reservations and alcoholism and how liquor stores are normally right outside the reservations. There are patterns systemically that we see. And so I think that a lot of the resources were deployed there, but there's also some, what do I want? I don't want to say governance, but some agreements between tribal councils and the federal government as it relates to how to address pandemics and certain things. So we can do a deeper dive into that, but that, again, that would be a long conversation for me to really get that information. But it is astonishing that the death rate was not as high as the hospitalization rate. But I mean, even in the Black community, you know, there's 4.7 times higher hospitalization, but it was 2.1 times higher in deaths. And so I'm starting to see just across all of these in that particular chart, hospitalization rates were extremely high, but the death rates were not as high as the hospitalization rates. So that is interesting.
We're also thankful for that. You know, that the hospitalizations didn't follow, the death rate didn't follow that hospitalization rate.
And I think that had a lot to do, and again, my hat's off to the first responders, that the frontline folk in the hospitals who don't get the credit, who don't get the pay that they should for this type of stress work, and hats off to all the first responders. And I have to say that all the time.
I would see, and I don't recall what state it was, but I just saw where one of the states, they are so, short people that are able to go in and work in those essential positions, because so many of them coming down with COVID, that they're now allowing the healthcare workers that have COVID to go in and work to treat the COVID patients.
Yeah.
Because of such a shortage.
Too. Yeah.
Yeah. I don't remember what state it was, but okay. We have an individual who's currently working on a project, and she would appreciate some advice from you. So here you go. So from a research perspective, in what ways do you think we can assess cultural competency in provider-patient interactions to reduce this healthcare miscommunication?
So I think that you have to first look at the implicit bias of the providers. Cultural competence is something that's being used. Cultural competence and diversity is used so much now that oftentimes you have to kind of redefine it depending on how you're using it. I'm thinking that if you do some implicit bias training and look at some cultural competence training for patients, for providers, it will be very telling on the type. If you were to rate or to get an assessment from your clientele on how they feel they're being treated from a cultural competent way, and then after you get that, then do some training and kind of see where your staff is, I think it'll be telling. And so I think that all health and human service organizations need to have consistent cultural competence training, not just one little thing where you get one little certificate and you say, oh, I'm done for the rest of my life, right? But we need to have ongoing training, and we need to understand that the more we understand each other and the more we're comfortable with each other, the more impact we'll see in the overall health of the people we're trying to serve. And so I think that that's critical. There are several different ways, and there are some research studies that are doing similar things to what you're asking, that are examining it from different perspectives. I haven't really seen a best practice yet for that. So again, send me an email, let's talk about that. And I'll give you some resources and some things that we probably can move forward with.
We appreciate your willingness to be so engaging with those on the call. So thank you. You ready to get a little bit political?
I don't know. And I do have to get off in about 5 minutes. So I do have to 6 o'clock. So this 6 o'clock will be my third presentation of the day, and this is a national one. So
well, we appreciate your time with us right now. So this is what aspect do you feel will be most important in implementing a new COVID plan in January with the new presidency? And what new policies do you think are going to make the biggest impact on these underserved groups?
Can you repeat the question?
So what aspect do you feel will be most important in implementing a new COVID plan in January with the new president?
What aspect do I feel will be most important? I think transparency one, because it seemed like there was a lack of transparency around COVID and around just the facts around it. So if you're going to build trust and you want people to buy into whatever the federal recommendations are, or whatever the federal plan is, you have to build trust. But before you can get trust, people have to feel like you're being transparent. And I think transparency, clear communication, no double-sided messages or messages that can be left for interpretation, 19 different ways. I think those are going to be critical in moving forward to addressing COVID, even with the new administration.
And then on a follow-up with that, what new policies do you think are going to make the biggest impact for our underserved groups?
What new policies? I related to COVID?
Related to COVID, correct.
That I'm not sure just yet. From a policy perspective, I don't think the country is ready to have a COVID policy yet. People don't even want the mandate to wear a mask.
Well, I was just going to ask you, because I think we should all wear a mask. I'm just going to put that out there. So what do we say to those individuals that think that that's not appropriate, that's not necessary? Clearly, they're coming at it from a different perspective. How do you respond to someone that wants to talk about?
I'm so glad you said that. I have friends of every persuasion and every political ideology. I have a friend who happens to not be minority and who happens to, hey, why are you wearing that mask? Are you doing it just because you're a public health professional? I said, well, why are you not wearing a mask? And he says, well, I don't believe I have to. It's my right, blah, 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 blah. And then he was saying, and I'm not worried, God will protect me, very religious, God will protect me. I said, then why are you toting guns everywhere? Why you need guns for protection? And you're worried about guns being taken away for protection, but you won't have protection in COVID. So, you're just gonna have to, you're gonna encounter a lot of different personalities and a lot of different angles on this. And depending on your relationship with those individuals will determine how you respond. And so, I actually didn't tweet it that day and said, the same God that you say would trust you with COVID should also trust you where you don't have to tote guns and feel like you're gonna be threatened if your guns are not on you or taken away, when you're talking about amendments and rights. And so it's just like it's your right to carry a gun, it's my right. It is also my right to feel safe around you in COVID and during COVID. And so, these political conversations are something, and they can trigger a lot of emotion and a lot of feelings, some justified based off facts and some not justified based off a lot of false information and myth. But yet the human being is still a human being. So yeah, just be wise as you're engaging in those types of conversations. That's all.
And wear a mask.
And wear a mask while you're being
Right.
wise.
I think I love what comes from our state of Michigan, which is, spread hope, not COVID. And I tell my students, spread kindness, not COVID too.
Yes.
Wear your mask. So
and I tell people, it's often like with when we had the law around seatbelts, it took a lot of people a lot of time. In fact, if the engineers hadn't started putting those beeps in your car, people probably still wouldn't be wearing their seatbelts, but they just get tired of hearing the beeping sound all the time. And then some cars now, with some technology, the car, they say, won't even start unless you have it on. And so it took a lot to get us to get there. And that was not to impede anybody's freedom. It was there to actually keep people safe. And so I don't look at the mask any differently than I do with the seatbelt situation, right? We're just dealing with the mask under a lot of stress and pressure with COVID and a lot of immediate deaths, and I can speak to that. My life has been impacted by COVID. I've had over 8 family members that have passed from COVID since February. And around March, right before the governor of Georgia finally mandated the shelter in place order, I had a cousin who was called to do jury duty the week before the mandate, and she went and did jury duty. And the week after jury duty, they found out that a person in their jury pool was tested positive for COVID. So they had all of them come in and get tested. Well, my cousin tested positive, and she happens to be the caregiver for her mother, who was in her early 70s. So she had gone home and then spread it to her mother. And then 3 weeks later, they both passed away. So for me, this is so real. So when people don't wear masks, I see my cousin and my aunt when people don't wear masks, and I can take it very personal. But again, as the public health professional, I try to have that dialogue and understand that even a person that's not wearing masks, they're running off information and experiences that may be different from mine. So then I just try to have a healthy dialogue and try to persuade and educate the best I can.
Right. We thank you for your time today, and we genuinely express appreciation for all you are doing to keep us safe, to look at these different inequities and what we can be doing. On behalf of all on the call, I know that you also pulled at our heartstrings sharing about your family. So we are very sorry, to hear about that. We offer some condolences there, but we do want to thank you for your time, on behalf of MSU's College of Human Medicine, Saginaw Valley State University, and Mid-Michigan Health. Greatly appreciate the discussion. We didn't get through quite all of the questions, but Dr. Key, you were kind enough to share your email. So watch for some follow-up that I'm sure will come through there. My guess is you'll have a spike in your Twitter followers as well, because you mentioned tweeting as well. But we want to thank you for your time. We understand you need to jump off and go do a national call, so we wish you the best with that. And to all of you on the call, thank you for spending your last hour of your afternoon with us. We wish you well, and we remind you to spread hope, not COVID, spread kindness, not COVID, wear a mask, care about the people around you, and go and have a great day. So thank you, everyone.
Thank you all.